Thank you so much, Dr. Maxwell, for this kind introduction and for setting the stage so beautifully for this next segment of our workshop. This is where we will be diving a little bit more into the implementation science by focusing on a specific study that was conducted by Dr. Natalie Douglas, titled Service Learning with Older Adults in Care Communities, Measures of Attitude Shifts in Undergraduate Students. A link to the study can be found in the agenda packet. So briefly, Dr. Natalie Douglas is a professor in the Department of Communication Sciences and Disorders at Central Michigan University. She will briefly present her study that will be used to frame the roundtable discussion a little bit later, and helping us to explore how we can build the evidence around pedagogy for measuring and changing negative attitudes in learners towards working with older adults. Dr. Douglas, the floor is yours.
Thank you. Thanks so much, Dr. Thomas and everyone. I'm so happy to be here, and I'm very grateful for this opportunity to talk a little bit about some of the work that we're doing here in the Midwestern United States. And as I received the invitation to join this really fantastic group, one of the major shifts in my own thinking occurred when I realized that I was using and thinking about implementation science as a researcher and thinking about some of those research to practice gaps in terms of clinical research. But what I was not doing was thinking about how implementation science could support the education that I was providing to my students. So for me, this has been a really big shift in learning experience, and I'm happy to talk a little bit about this study that we did with service learning, where it actually was not done with an implementation science lens. And the goal is that by the end of our discussion, we can think about ways that maybe if we would have used an implementation science lens, potentially how that could better transform health professions education, which is really what we're trying to do with this pre-workshop series. So let's go ahead and go on to the next slide. I really want to acknowledge my co-authors, Sabine Huer, who is at the University of Wisconsin, Milwaukee, and Tanija Burney and Rebecca Willer. So all kudos to them, most certainly. And the next slide. So this is a quote, speaking of attitudes, of one of our undergraduate students prior to the exposure or the service learning experience. So he says, before arriving, I pretty much thought I was going to a mental hospital. I thought the residents were going to be these hollow husks of a person, and I was going there to entertain them for a bit. So thinking a little bit about some of the slides that Dr. Maxwell presented in terms of attitudes, ageism, we definitely kind of see this exhibited in this first quote here. So let's go ahead to the next slide. So what is the problem, right? So we've already heard this afternoon that ageism may really steer our students in our healthcare professions away from working with older adults. And we know that based on the need, that we really have to think carefully about what it is that we can do about that. We know that ageism is going to potentially lead to many negative attitudes towards older adults, especially people living with dementia. So next slide. And so what is the solution? So I'm definitely not here to say that service learning is the end all be all solution, but I do think that we have some evidence that shows that if we expose our undergraduate students to older adults, both along the continuum from healthy aging all the way through those living with even severe dementia in some cases, we have the opportunity to really influence some of those negative attitudes. So what you see on this slide are some of the citations that purport the evidence for service learning, right? So we know that service learning is part of an evidence-based instruction where we're really combining these real world experiences with advanced learning and conceptual ideas. And we know that we have the potential to influence attitudes. So some other key pieces to service learning include the mutual need. So it's not just the student who would benefit, but ideally, whichever community where the service learning was taking place, there would be a need met for that community as well. And then we also know the critical need for reflection when we think about service learning activities. Next slide. So in this particular project, we wanted to see, are we able to move the needle when it comes to undergraduate student attitudes after a service learning experience? So we looked at the dementia attitude scale, and we also analyzed the journal entries at 3 different points in time of our students participating in this project. Next slide. So we rooted our work in a framework that was developed by our colleague, Dr. Nidhi Mahendra, that is the AAA framework, where 1A stands for awareness. So we really wanted the experience to emphasize that the students are acquiring knowledge and starting to develop those skills in self-reflecting, thinking through, okay, where are my gaps in knowledge, and being able to self-identify some of those gaps. The second A is application. So during our preparatory training, we're really trying to think about ways that we can support and train interactional skills with older adults, yes, but also as a way to hopefully improve clinical practices down the line. So one thing I'm not sure that I said, these are undergraduate communication sciences and disorder students. So these are students who are likely going to go on to get a graduate degree in either speech language pathology or audiology. And then the last A's are advocacy and attitude. So really thinking through this idea that an attitude shift may occur when we are reflecting and when we are going through new experiences. Next slide. So we had 145 undergraduate students across 2 universities during 1 semester. So a mean age of about 21 and a half. We had mostly female participants. As you can see there, we have some major diversity issues in our field that we are working on. And the other important point here is that less than a quarter of our students in this particular sample had any experience working with adults living with dementia. So these are really students who are very new, in many cases, to older adults as a whole, and specifically to dementia. Next slide. So throughout this service learning experience, students ranged from an average of 15 to up to 30 hours weekly interacting with persons living with dementia in a long-term care community. So this could be an assisted living community, a skilled nursing facility, or a memory care community, something along those lines. It ended up being between about an hour or 2 weekly throughout the semester. And prior to the students participating in this activity, we had a lot of training. So some of the students went through time slips training, which is a reminiscence and storytelling protocol. There was communication partner training. So how to be a communication partner that supports the differing communication needs of people living with dementia. So thinking about ways to maybe use icons or photos or writing keywords, gestures, ways to interpret nonverbal behavior. These were all included. Thinking through meaningful activities that could be done with people living with dementia, anything from crafts to games to potentially more of a person-centered approach based on an activity that maybe had something to do with the person's job or hobby or interest prior to when they joined the long-term care community. We also had some sensory activities. And thinking about, when we say sensory activities, we're thinking about our folks that are living with very severe dementia. So maybe they appreciated having a scratch on the back, or their hair combed, or rubbing lotion on their hand, or sometimes just holding their hand as a piece of that human connection. So these were things that we trained the students on in class prior to participating in the experience. Next slide. So one thing that we want to be very straightforward about is the resources required to complete a program such as this. So I already talked about classroom instruction. We also had some on-site coaching and support. And then we also had community partnerships where we had willing communities that really wanted our students to participate with them. Also, even something that seems as silly as physical space, right? So where are these students and people living with dementia going to go? This was all conducted pre-COVID, but even now, you know, a resource such as physical space is not something to take for granted, certainly. Next slide. So this, hopefully you're able to see this. This is an analysis of the results of attitude. So using that AAA framework that I mentioned earlier, what you see in this first column here, blue stands for positive attitudes. So something in the student's journal entry was coded as positive. The green stands for negative. So something in the student's journal entry was coded as negative. And then this neutral color here, beige, neutral. So something in the student's journal entry was coded as neutral. So this is our first time point here along this horizontal axis where you see number 1. So the initial experience, and you see the positive number of codes that we have there. And over time, hopefully you're able to see the gradual increase in positive codes by the time we reached the 5th or that final point in time when we analyze the code again. Hopefully you're also able to see, in addition to the increase in positive codes, we also saw a decrease in the negative codes. So next slide, please. So we really were able to see some increased positive attitudes toward this population, and we were able to document this attitude shift over time as indexed by the changing proportions of positive and negative attitude statements from the student journals. And then we also, as I mentioned, looked at the dementia attitude scale, which also confirmed these attitude shifts. Next slide, please. So I left out the ending of the quote that we started with, where the student says, before arriving, I pretty much thought I was going to a mental hospital. I thought the residents were going to be these hollow husks of a person, and I was going there to entertain them for a bit. But then the student goes on to say, I couldn't have been more wrong. So this is something that occurred towards the end of his service learning experience. Next slide, please. So this is the caution, right? So as good as it is that we were able to get some positive outcomes, what was absent from this was an explicit implementation science lens from the beginning. Next slide, please. So Dr. Thomas is going to lead us in a discussion where hopefully we can think about, through this example, and some of my colleagues are going to be presenting some additional examples based on their local context, how can we really use implementation science to provide a wider lens to think about how we can really systematically transform education to meet these great needs, right? So it's not to say that it's overly negative, this study that we have, but if I were to have an implementation science lens, there's likely several elements of the study that I would do differently. And I also think that thinking through this wider lens, it provides us with an opportunity to think about, well, maybe there's more than just doing these individual studies across our institutions individually, but how can we kind of use a wider lens to really transform all of health professions education? So I'll turn it back over to Dr. Thomas. Thank you so much.
Thank you so much, Dr. Douglas, for the wonderful presentation, and I'm quite excited about the roundtable discussion. As I'll be talking about in a few minutes, we often talk about determinants of implementation, right, as constructs that have been associated with effective implementation efforts. Often researchers think of determinants as the barriers or the supports, but they could also be mediators, moderators, predictors, and or outcomes. Could you describe what some of those determinants of implementation in the form of barriers and facilitators that you experienced in your study, and why?
Sure, absolutely. Thank you for that question. So I think in terms of barriers, I mean, one thing is for certain, this was conducted before COVID. So we did not have the host of barriers that are present right now. So I think anyone, we were just this year, towards the end of 2022, able to kind of go back into some of our facilities. But it does lead me to some other barriers of the logistical challenges, right? So does the community have a volunteer coordinator or somebody who's designated to help kind of be that on-site person with institutional knowledge, right, of how things work in that long-term care community? We had some barriers in terms of volunteer training of our students, all of the paperwork that goes along in terms of certain communities being more or less regulated. So there were things like TB tests and other requirements that the students had to really think through prior to coming. And that really caused some barriers in terms of completing this experience. Furthermore, thinking about coordinating schedules, right? So when is a good time, because we know that sometimes in long-term care communities, there's a very, I don't want to say rigid, but there's a schedule, right? There's a clock of when things are happening. And when our students can't get their schedule to work around the community schedule, sometimes we've got some logistical challenges there. And then what I was not anticipating as a barrier was the beautiful relationships that were made with our students. And then when the 15 weeks are done, then they go away, right? So what is the ethical thing to do when you bring these students into a situation and then there's all of these extra resources and volunteers, and then all of a sudden here comes the holiday break and then they're gone, and then we have to train in a new batch of students? And how do we think through some of these challenges? So those were some barriers. For facilitators, again, I think it's important to note that there was some support for community engagement at the level of my institution and at my colleagues' institution. So they were applying for a certain Carnegie classification to be community engaged. So they were very motivated for these types of endeavors. And I think, again, because we had that relationship with these community partners, there were places where the community partners would realize, wow, well, if they start with us now, maybe they'll want to do their internship here, or maybe they'll want to work here, right? They're starting, because the relationship lasted for several years, they started to see the benefits of some of that engagement earlier on at the undergraduate level. And we also had some additional graduate student support to provide some coaching on site when our undergraduate students would get stuck. So that, I mean, that was definitely, those were all facilitators that really supported the implementation of this experience.
Thank you so much, Dr. Douglas. I think that that's going to really set us in nicely for the rest of the afternoon. Before we actually go into the roundtable discussion, I'd like to just spend a few minutes discussing the role of knowledge translation and implementation science in supporting an evidence-informed approach to health professions education. So if you can bring up the slides, please. Thank you. So I'd like to also thank you for inviting me, not just to speak for a few minutes here, but also to moderate this roundtable discussion. So I'm Aliki Thomas. I'm an occupational therapist by clinical background and an associate professor at the School of Physical and Occupational Therapy and the Institute of Health Sciences Education in our Faculty of Medicine and Health Sciences at McGill University in Montreal, Canada. And I'm an implementation scientist, and my work is really at the intersection of education and practice, trying to promote both evidence-informed HPE, but also evidence-informed rehabilitation practices. So next slide, please. So I think we would all agree that an evidence-informed approach to, I'll just say for short, HPE from now on, really helps us ensure accountability to our learners and to society in providing meaningful and effective education for our future healthcare professionals, and helping often resource-strained systems via more streamlined and cost-effective practices. And as we've seen already in this first hour, and building on Professor Anyas's talk, knowledge translation and implementation sciences are powerful lenses that can really help us move the evidence-informed HPE agenda forward. Next slide. So just 3 clicks for the 3 figures, please. So essentially, when we talk about how to actually move evidence into educational practice, I'm going to take a minute or so to walk you through these 3 stages. So the first thing we often think about is to identify where the problem actually lies. So the nature and the magnitude of the research to practice gap, to try to figure out what are those factors or those determinants, as we just heard Dr. Douglas tell us about. So the factors that will support or inhibit the use of the evidence into educational practices and policies, and then trying to really do something about it in terms of designing, implementing, and evaluating interventions to reduce those gaps. Next slide, please. So just a little bit more specifically, when it comes to health professions education, and we'll have an opportunity to discuss this with our roundtable as well, what we're looking at is to answer the question, to what extent do current educational practices vary from best practices or vary from the scientific evidence? So what do we know about using different pedagogies to, for example, this afternoon with our topic on learner attitude? So how far is what we are doing from some of the best practices? Next slide, please. So in terms of all 3 clicks, please. So when we talk about the factors that influence the use of research to inform practice, we tend to think about those determinants at an individual level, an organizational level, and a systems level. So thinking a little bit about our pedagogical approaches, some of the supports or barriers may be at the level of the teacher or the preceptor, and maybe about their knowledge, their attitudes, their skills. Might be organizational level factors such as the resources resources that we have available, the culture of a school or a department or a program, and our readiness for change. And at a systems level, we're talking about educational and healthcare reforms that often trickle down into the actual programs, or it can be accreditation standards, for example, that could be a support or a barrier. Next slide. So when we think about designing and implementing interventions, we're talking about targeted theory-informed interventions to address the barriers, but also to promote uptake of the evidence-based pedagogy, looking at also leveraging some of the supports. So you're thinking about questions such as, what do you want your intervention? So that knowledge translation intervention, often we call it a faculty development intervention, to achieve and for whom? What comprises the intervention? That's the ingredients. How would you propose the intervention will work? So what do you believe will be some of the outcomes and why? And how do you want to deliver this intervention for your faculty or your preceptors to try to move closer to an evidence-based or an evidence-informed approach? Next slide, please. So without going into too much detail, I think what's really important to talk about here is that there's many frameworks that exist to support us in this endeavor. And what this figure shows you is that they tend to be organized around process, so moving evidence into practice. There are frameworks that focus specifically, as you can see in the middle, in trying to better understand what influences implementation outcomes, what I just called supports and barriers. So we see determinant frameworks there in an example, but we also are very much interested in evaluation of the implementation process and have access to evaluation frameworks to do that. So this is always something that's really interesting to keep in the back of your minds. Next slide, please. So when we think now specifically, moving on to evidence-informed health professions education that could better prepare our learners to address some of what Kathy mentioned earlier with respect to the need to prepare our students for working with an aging population and using an implementation science lens, so bringing everything that all my colleagues have said this far, what could it look like? What should we be considering specifically? Next slide. So just to zoom in a little bit more, when we're talking about documenting what you're currently doing in your programs, you can use accreditation reports. You can review evidence on learner outcomes. Here, as we saw from Dr. Douglas, we're interested in outcomes related to attitudes. We want to essentially be able to map what is being done across a curriculum or across a program of study. And our outcome is to look at the extent to which there's alignment between the evidence and what we're currently doing to better prepare our learners for a workforce and for working with older adults. Next slide. So in the middle, when we go back to thinking about the factors that influence, there's many ways that we can do this. We can interview teachers and preceptors and program directors. We can use focus groups. We can survey faculty. Again, what we want to accomplish here is to identify what might be the supports and barriers at these 4 different levels. Next slide. And finally, when we're talking about implementing and evaluating AKT interventions, once again, we're interested in what can we do to address the barriers that we identified. So Dr. Douglas talked about some of those barriers. And so here they would be about developing interventions to try to mitigate for those. So we might be interested in increasing faculty's knowledge about service learning. We might be wanting to look at confidence of faculty and preceptors. We might have limited resources. Some of the best strategies or evidence-informed health professions education pedagogies might be more costly. We want to think about what are the local needs in terms of the actual program, which stakeholders need to be involved, how much buy-in do we have from our colleagues, our chairs, and our directors. And we can use multiple, this is really not an exhaustive list of KT interventions, but presentations, questions and answers, testimonials, videos, and webinars. There are multiple strategies and faculty development activities that can be used to address some of the supports and barriers. And thinking about how we're going to do it, again, there are multiple ways and strategies to use, as you can see here, from face-to-face, online, etc. Next slide. So in conclusion, what I'd like to mention is that health professions education should really rest on sound educational strategies and pedagogies. And evidence-informed health professions education requires that the decisions that we make decisions be made using the best available evidence on the effectiveness of a pedagogical strategy, such as the example Dr. Douglas gave on service learning, but that we consider all the possible multi-level supports and barriers that might help us or stand in our way. Once those factors are identified, we're in a much better position to tailor and to design KT interventions to leverage the supports and target the barriers. And as with most academic and scientific endeavors, we want to be able to create a loop whereby we research the effectiveness of those interventions to help advocate for continued resources to sustain the implementation of these new evidence-informed pedagogies. Next slide. So that is just a bit of a lightning overview on evidence-informed HPE and how IS can help. So I'm actually now incredibly pleased and excited to introduce our roundtable discussion. So we're going to shift to our distinguished roundtable discussion. So I invite you to turn on your cameras, where they will share reflection on Dr. Douglas's barriers and facilitators, discuss whether the barriers and facilitators apply to the setting and populations the panelists work or educate in. To do this, each panelist will share 2 slides, one that gives us the context or setting in which they educate, and the other, a description of relevant determinants. I will just add that although Dr. Douglas's study is about service learning with persons living with dementia, the panel will not just focus on dementia, but will look more broadly at working with older adults. So now that everyone's cameras are turned on, and I will welcome our first speaker, who is Dr. Toby Brooks. So Dr. Brooks is the athletics training program at Texas Tech University Health Sciences, and he will be leading us off. Dr. Brooks, the floor is yours.
Thank you, Dr. Thomas. Really appreciate the opportunity to be here and chat with everyone. So as Dr. Thomas mentioned, I serve as a faculty member at the Texas Tech University Health Sciences Center, which includes our School of Medicine, School of Pharmacy, Public Health. I'm in the School of Health Professions. So if you go to the next slide. So our program specifically is a graduate program in athletic training. And a lot of times people hear that word athletic and they jump immediately to maybe a concept of a personal trainer or someone who only works with a very young population. And that's just not the case. We have an opportunity to work with and serve patients from across the age spectrum. And so we find that part of our challenge is educating not just the public, but also other healthcare professionals. So at our institution, we are part of an interprofessional integration model. Our Department of Rehab Sciences includes occupational therapy as well as physical therapy, and then a PhD and some post-professional programs as well. And so we have in recent years focused on also developing clinicians as educators and looking at the importance of acquiring teaching skills at the same time as learning clinical skills. So as far as our relevant determinants, as Dr. Thomas mentioned, next slide, we do look at these determinants. I don't know if it's necessarily on a continuum, but it's certainly on a range between individual, organizational, and systematic. And so we work individually on helping build new knowledge, skills, and ability, and as well as helping to reinforce them. And so that can be didactically in the classroom, that can be clinically when they are out doing their clinical experiences. An area that's near and dear to my heart is, it was alluded to earlier in today's session, where Lordy's work, where this concept of resilient beliefs really kind of battle and combat your efforts as an educator to help students acquire new skills. And so it doesn't do any good to continue to chip away at knowledge when the underlying belief remains unchanged. So that's both individually as well as organizationally. We also are a values-driven program and organization. That sticker you see there, that's our QR code that we use to honor and recognize when students, preceptors, faculty are living out our values of excellence, professionalism, resilience, agility, and servant leadership. And really, that's great to talk about values, but what's the impact of them? Is it really moving the needle on our efforts to improve educating that next generation of healthcare professional? And then lastly is really systematic. It's fairly specific to athletic training. Unlike the other programs in our department, that third-party bill, and that really shapes how healthcare is delivered in those respective fields. AT is really at its infancy when it comes to this. We've had CPT codes for some time, but only recently have states reimbursed for that. So the typical model is an AT is going to be embedded at a higher education institution or high school, secondary school, and basically they're just paid. They're not necessarily generating revenue. They're seen as more of an expense. And so those factors are specific to AT, but those are certainly determinants that we look at. So I love the idea of conceptualizing implementation science and then looking at the many ways that it could be implemented. And it's really just context. The concept is the same, and using this as a model or a metric by which we can see if our efforts are actually, again, moving the needle. Is it making a difference? Otherwise, we're just really guessing. So I love the application of implementation science in any setting. And so this is just another example of that.
Thank you so much, Dr. Brooks. And my apologies, I did forget to mention that you are also the Assistant Dean for Faculty Development. And I think that because of this topic today, that's even more important. You bring up, I love your comment about context and how incredibly important it is, whether that's in education or clinical practice. Context matters tremendously when it comes to evidence-based practices. So moving on to our next panelist before we open up for discussion is Dr. Kim Dunleavy. Dr. Dunleavy is a clinical professor and the Director of Community Engagement and Professional Education at the University of Florida Department of Physical Therapy. Dr. Dunleavy, the floor is yours.
Thank you, Dr. Thomas. I really appreciate it. And I'm going to be taking a slightly different slant where we wanted to take a look at what we're actually doing in service learning currently, and then seeing, could we take the same type of program that Natalie talked about earlier, and would it be applicable? Can we change it just to be able to increase the emphasis on attitudes towards aging? So we have a number of different current service learning programs that are primarily in the first and second years of our Doctor of Physical Therapy training, including interprofessional home visits, which is a health sciences wide program, very well-established program with almost 800 students who are paired up in groups, who then go to an older adults. It may be older adults, but it doesn't have to be. It could be families, and they meet with them for 2 or 3 sessions in the first semester and 2 in the second semester. And then there are seminars related to specific topics, social determinants of health, life situations, etc. So some of our students are paired up with older adults. We have a number of different volunteers who like to work with students. They like teaching, and this becomes a source of teaching for them, as well as our students have a project to work on to meet some of their needs, whether it's just resource-based information or helping with digital access, etc. Then within the PT program, we have a number of options that students are assigned to in their first year. We have a community walking program. We have a low-income housing chair exercise group. And then actually pre-COVID, we also had a balance and falls activities in the senior center. And then we have two other groups. One is adaptive gymnastics for children with disabilities, both intellectual and physical. And we have our pro bono clinic. So the reason the big square is in the middle is that the community walking program, the housing exercise class, and the senior center all definitely cover older adults at whether it's active aging or chronic diseases, or some that are actually starting to get in towards what the geriatric syndromes. The interprofessional home visits may involve older adults, but the adaptive gymnastics and the pro bono clinic groups do not. So our students may or may not have extensive involvement in the service learning activities, which would meet the attitudes towards older adults section. It's varied. Next slide, please. So starting to look at the determinants, these are established service learning activities. We could go and look at some of our outside partners. We have a number of residential units. We have a number of retirement facilities. We've got some pretty big ones just down the road, which covers every spectrum of aging. And all of those would be possible. But as we looked at determinants, one of the facilitators would be our established programs, and seeing if we might be able to fit the learning activities and the situated learning activities in. And prior to the geriatric course, which is later on in semester 5, to increase the exposure to older adults and potentially actually in the geriatric course, then finishing it up in that particular semester. In the first 2 semesters, the requirements for service learning are integrated into health promotion classes, and we use examples across the lifespan, but all of the activities there focus on elements that could be very, very relevant for working with older adults. Communication, using either the International Classification of Functioning model or the biopsychosocial model, population health elements, and definitely health promotion and prevention. So what the service learning activities are actually a student run as well. So we have a number of students who actually take on leadership roles in their second year. And we do, as a critical part of service learning, as Natalie mentioned earlier, is we do reflections. So the reflections could be areas where we could take exactly the same model that Natalie talked about and just change the way that we're looking at the reflection with maybe some different prompts and maybe some different surveys to change the emphasis. Next slide, please. So if we were starting to look at proposed strategies that we might want to think of to work on ageism, attitudes towards aging, I think one of the things that, as Aliki talked about earlier, is how do you collect the information? And one of the first things that would be relatively easy to do is just to look at the number of students that are working with older adults in these service learning activities. How much exposure do they have? Whether it's in the interprofessional activities or in the service learning groups, and then the individual student characteristics. You know, are they coming in wanting to work with older adults, or do they just want to work with athletes who are the same age? And their attitudes towards working with older adults. One of the big things we have found is that there's also extremes towards involvement with movement and exercise. So we have some students who are really very concerned about working with older adults, that they might push them too hard, and they won't push them even just a little bit. Others who will push them way too hard and not take into consideration that they may have pain, osteoarthritis, any types of limitations for their function. Other elements in terms of looking at barriers and facilitators, faculty communication, just by working with faculty on their debriefing for particular activities could be a major change. But faculty supervision is critical for these service learning activities. So we would definitely have to work with training, communication with faculty in the service learning activities, and then also look at the integration into the geriatrics course, which is we have an outside clinician coming in who teaches that course. And that, I'm sure all educators in the room, sometimes the communication when you have full-time faculty versus part-time faculty can be a barrier. So ideally, looking at explicit objectives, I think it was Kathy who talked about the implicit curriculum, really making it very explicit and adding some of the training. So Natalie will be trying to use your training in the future, and looking at some activities in the classes with the potential of additional service learning requirements if the students have had less exposure. And then finally, sort of wrapping it all around, is to look at adjusting the reflection questions, because even something as simple as how you phrase your questions on your reflection can elevate the importance of what you're looking at and how people do think about it. And as part of service learning, it really is one of the critical components. And we find that sometimes students we have them go back and look at their reflections in their second semester, look at the first semester, and they start to realize maybe how they've changed or the things that they have progressed in. I do think one of the things that we would need to adjust would be the instrument. In Natalie's study, she used an instrument for attitudes towards dementia. And I think we would need to use a validated instrument towards ageism and aging that would reflect the sort of active aging type of population that we are working with. So thank you so much for the opportunity, and I'll hand it back to Aliki.
Okay, so great. Thank you so much, Dr. Dunleavy, for that. We're going to move on swiftly to the last two panelists so that we can have a good roundtable discussion. There's lots of exciting ideas, and I see things in the chat already. So moving on to Dr. Hannah Wilson. Dr. Wilson is an assistant professor and in the Department of Nutrition, Dietetics, and Exercise Science at Concordia College. Dr. Wilson.
Thank you, Dr. Thomas. So like Dr. Thomas said, I'm an assistant professor in the Department of Nutrition and Dietetics at Concordia College. I'm also a registered dietitian. And I serve as the program coordinator for our combined Masters in Nutrition as well as our dietetic internship here at Concordia. If you can go to the next slide. So at Concordia, we have both an undergraduate nutrition program as well as, like I just said, a graduate program and an internship. So both of our programs are accredited, and if you're not super familiar with the nutrition and dietetics field, what we are preparing our students to be is registered dietitians. So we have a very clear, direct career path for them. Registered dietitians work across a ton of different settings, many of which cater to older adults. So I have a picture of a long-term care facility, Cheyenne Crossings, here in our Moorhead, Fargo, North Dakota area, which we're located on the border of North Dakota. And so we have dietitians that are graduates of our program there. A lot of dietitians work in just hospitals, outpatient clinics, and obviously a lot of older adults are the patient and clientele there. We also have dietitians who work in more community-based settings that work in programs like Meals on Wheels, which is a meal delivery service for older adults who can't prepare food for themselves or go to grocery stores, that kind of stuff. So dietitians all involved in the older adult setting. And so we feel it's really important, and it's a really high priority for us to train our students to, one, be interested in that, and two, to be prepared to serve that population. So we have integrated a variety of different service learning opportunities at both our undergraduate and our graduate levels at Concordia, as well as many other nutrition and dietetics programs across the US. These two bottom right pictures, these are obviously not pictures of our students with older adults. I did not have any with our undergraduates, but that is an example of some of the service learning opportunities that we incorporate in our undergraduate program. And then at the graduate level, we have, and I'll talk about this on the next slide in a second, we have required supervised practice hours for our internship. And they, a lot of times, are placed in long-term care centers. So the pictures in the bottom left are of a soda shop theme meal that one of our graduate students and dietetic interns put on at a long-term care facility in the area. So those are just some examples of where we place our students, what the field looks like in terms of older adults, that kind of stuff. So next slide, please. So some specific barriers, facilitators that we encounter specifically at Concordia and in our area of Moorhead, Minnesota. We are in the Midwest. We are located on the border of North Dakota, so we actually use a lot of sites in North Dakota and not in Minnesota. But even still, we are in a pretty small area, so not a ton of supervised practice practicum sites that we can pull from. In general, though, in nutrition and dietetics as a whole, we have a shortage of registered dietitians to serve as preceptors and mentors. And so that is certainly a barrier to integrating service learning in both our undergraduate and our graduate programs. We have to try to overcome this barrier, place students with preceptors and mentors who are not actually registered dietitians themselves. Our accreditation agencies allow that in certain instances because they can certainly learn skills around managing a food service setting or something like that from someone who's not necessarily an RD. So we've gotten around that, and especially long-term care facilities, and just placing them with people who are not registered dietitians. But thinking kind of visionary and long-term, to prevent that from being a cycle of having a shortage of RDs and more long-term care settings, we are really, really intentional about trying to get as many students into those settings as we can to hopefully engage them and get them interested in that population, to try to break that cycle. So that's one of the strategies that we've used to try to overcome that barrier. I mentioned we do have a limited number of sites in the Moorhead-Fargo area. We are actually one of 3 colleges and universities in the area. So we are all competing, not really competing. We have the same end goal, but we are competing for the same sites, essentially for our students, again, both at the undergrad and grad level. So to get around that, we are in communication with other program directors, program coordinators at those colleges and universities to try to alter when we're placing students in sites, so we can kind of trade off when we're using preceptors. So being in good communication with other program directors has really helped us get around that barrier. We've also found, and this has kind of come out of COVID really, is that for especially at the undergraduate level, when their practicums are relatively short, so like a week, 2 weeks, and they're working in settings that require background checks and different TB tests, vaccinations, that kind of stuff, we found that a lot of those sites, because they do take the cost of those tests and background checks on their own, that they find that those costs are just too much of a barrier and are not feasible for them for the short amount of time that they have students on site. And so for that reason, they have just stopped taking students altogether. We encountered that issue with Meals on Wheels this past year. We don't require our students to do a ton of hours with Meals on Wheels, and so they just felt like it wasn't worth it for the cost of the background checks that they were having to run on all of those students. We haven't necessarily figured out a way around that yet, I'll be totally honest. We have looked into trying to obtain some funding that we ourselves can put forth to cover the cost of those background checks, et cetera, so we can get our students access to those opportunities. And again, I mentioned scheduling. That's always a really big challenge. We have 12 graduate students running at one time, which depends on the program, but that's relatively average for graduate level nutrition programs. And so that might not seem like a lot, but when they have to each do 1,200 hours of supervised practice over a 9-month to 2-year period, it can be a pretty big challenge. And so again, keeping in communication with other programs directors and coordinators is really valuable. We do have some facilitators, so it's not all just challenges, barriers that we're trying to overcome. So I mentioned I'm at Concordia. Concordia is a small liberal arts college, so it's kind of unique that we have 2 accredited nutrition programs at such a small school. But from the liberal arts perspective, Concordia has a university-wide requirement for what we refer to as PEAKS. PEAKS stand for Pivotal Experiences in Applied Knowledge, which is a fancy way of saying they have a service learning requirement for every single student that graduates from this college. So students have to complete 2 PEAKS before they graduate. Our nutrition program, undergraduate nutrition program, from the service learning that we've incorporated into our courses, and program meets those requirements through things like Meals on Wheels and other service learning opportunities. So having that university priority on service learning has absolutely been such a huge benefit for us to support our efforts in trying to get access for service learning opportunities for our students. And I mentioned at the graduate level, all of our students have to complete at least 1,200 hours of supervised practice. So they have to, basically their lives are service learning and practicing a lot with actual patients and clients with other dietitians. So that's a little bit about our setting. So I will turn it back over to Dr. Thomas.
So thank you so much, Dr. Wilson. So we will end the brief presentations with our final panelists, and then we will have a good 20-25 minutes for discussion. And I'm keeping tabs of the questions in the chat box. So I would like to now invite Dr. Ewan Williams. Is Dr. Williams? Yes, okay. Dr. Williams is a research associate in the Department of Health Sciences and Research at Medical University of South Carolina. Dr. Williams. So do we have Dr. Williams? Just give it a few seconds. So Hannah, do we have Dr. Williams? I think we don't.
I think he disconnected.
He disconnected.
Let's give him one more minute.
Let's just take a few seconds. Everybody can have a sip of water, including our panelists who were wonderful. I would invite the audience to think about some questions, because we have a real rich panel of speakers that I think could really shed light on some of the questions. We're specifically going to be going into questions such as, is this a priority? So this being challenging attitudes of learners towards working with older adults. So does something actually need to be done? Do we have an urgent problem that needs to be resolved regarding how best to promote or teach or foster the attitudes? And I'd like us to also have a discussion around the supports and barriers to doing that. And we've heard already some thoughts, and then the actual implementation strategies. So Hannah Guthrie, do we have Dr. Ewan? No?
I'd say let's move into Q&A.
Yeah, that's a good idea. Okay, so I'm just going through the chat box here. So perhaps as I do that, because there's several that have come in, could one or more of our panelists begin us with is this a priority and how big of a problem this is? And then I will look at questions in the chat box. So panelists, please turn on your cameras and your microphones and go ahead, please.
I can start us off. I kind of mentioned this, but a lot of what we focus on from like a medical clinical perspective in nutrition is malnutrition. Older adults are at much greater risk for malnutrition and nutrition risk for a variety of reasons. And so I teach a lot of our more clinical courses. And so I bring this up all the time, that most of the population that they are going to be working with is older adults. Most of our students are actually pretty surprisingly interested in the past couple of years in working with older adults for maybe reasons related to COVID and the increased risk that older adults had with complications from COVID. I'm not exactly sure, but yeah, it's absolutely a priority for us. While we do have some students interested in more of like sports nutrition and kind of, that's not a trendy topic, but more trendy topics, they do tend to be pretty interested in older adults. And so it is a priority for us.
I'll jump in.
Yes,
I think, it goes, it's not just about whether people are interested in it. We don't have huge numbers of people going into specialty practice in that area, but I think every single graduate should be prepared to work with older adults just based on the aging population, based on the, I think the iceberg analogy was an amazing analogy. If you really think of what we're preparing for people down the road in terms of prevention, I think it's absolutely essential. And I think it is also linked to the high prevalence of sort of chronic disease, the complexity in older adults, and the need to have the skills to be able to manage all of the complexities with healthy aging and safe progressions.
Mhm. Thank you for that. I see a comment in the chat box from someone who says, older folks tell me that we don't understand what it's like to be that old. And so I wonder for our panelists, how we could begin to even approach that, right? That this notion that as sensitive or as empathetic or as understanding that our learners are, they're not older adults and they'll never really feel that they're not in their shoes. And any thoughts on that? I think that's a really good question. Any thoughts? I see Dr. Douglas is nodding.
I'm just nodding enthusiastically over here. And if anyone, this is really coming from my clinical experience and anecdotal, not from any evidence, but I think there's so much power in that empathy component, as you mentioned, and just agreeing, yes, I don't know what it's like to live with dual sensory loss and potentially cognitive impairment and all of the, hearing loss and all of these aspects that, potentially happen as the aging process. And I think that empathy can go a really long way. And something that we talk about quite a bit in our class, as much as we, and again, this is with the dementia population, as much as we want to encourage life participation and the present moment and really decreasing suffering of people living with dementia, we don't want to eliminate the grief that goes along with it, right? And the suffering and the heartache and the hard times. So it's almost a paradox of, no, I don't understand, but I also want to be with you, right? And I want to support your participation in life and your quality of life. And I think a lot can go with empathy.
Mhm.
But I would be really interested to hear what others have to say.
Yeah, but one could make the argument that the same would be with MS or any other condition, right? We also don't know what it is unless we are experiencing it. So yes, thank you. That's a really good response. Thank you. Does anybody else from our panel want to say anything, or do I move on? We do have several. Anyone want to add about this? We don't know what it feels like to be an older adult.
Yeah, I'll jump in on this one.
Yeah, please.
We utilize whether they are alumni from our program or sometimes identified patients from my history or from my faculty's history. And one thing in particular that I found is effective, if we talk about a relevant topic that tends to be thought of only in the light of the young, healthy patient. Frequently we'll discuss a topic like Red S, previously female athlete triad. And we always think about that from the standpoint of that 14 to 22-year-old collegiate athlete or high school collegiate athlete. But what we've been doing lately, just to point out the totality of the life experiences, how those early symptoms manifest later in life, and bringing in individuals who have had problems with early osteoporosis or with any number of conditions that all started when they were an 18-year-old athlete, and now at the age of I won't throw a number out there, but later in life, it continues to be problematic. And so that really helps put a face and a name and an emotion to a condition that just lived in a textbook or lived on a blog post or something. And so I found that our students really respond favorably to that. Another aspect of that is the service learning component, where whether it is our students doing Special Olympics events so that they get connected to patients with special needs, or doing things in the community like recreational running events so that they can see, there was a 95-year-old athlete that completed a half marathon in an event that our students worked with, and they really get to see that, and it expands their perceptions of what athletes are. And there's really no replacement for that other than that firsthand experience. So
Right. And I know I see a comment in the chat box also from Dr. Douglas in response to simulation, right? So simulation can be a very powerful strategy to get us a little bit closer. Oh, here's a really good question from Catherine Colasa. This is really a good question for those of you that actually presented using it, service learning. Do administrators appreciate the amount of time it takes a faculty member to manage service learning or other IPE? What a great question, particularly after I finished presenting all the levels of supports and barriers. Any thoughts from our panelists?
I'll jump in there. I think that's one of the big barriers, and parallel to that, it's the amount of time that it takes and the schedule. So being able to schedule it at a time when it doesn't conflict with other classes, or what happens when something goes wrong, you have a hurricane and you got to make it up. Some of those types of barriers do make it much harder. But honestly, the real world experience, the students like it. They get a lot out of it as long as it's structured and based on some clear instructions along the way, but it takes work. I mean, the service learning activities that we've been doing have been going, I've been at UF for 8 years, and they've been going for longer than that. And it does take time to be able to develop good relationships with your partners, to be able to actually, maybe change it a little bit here and there, but from year to year, it needs to build. It's not a one-off, let's just do something this semester and we're done. It is an investment. And so you will need to have administrators who are supportive of situational learning, experiential learning, and the benefits that it provides the students.
Mm-hmm. Any other thoughts from our panelists on support from program directors or? Okay, there's another really good question. Panelists, has anyone measured or assessed the implementation outcomes within your educational programs? Do you have plans to measure your implementation outcomes, and how are you going to measure your outcomes? 3 questions into one, but I think 3 very important questions. As I was mentioning in my little part, that's, being able to measure outcomes is going to be important for the sustainability and for advocating for resources. So what are your plans, panelists, and have you?
We're in the early stages of this. I love a quote. I don't remember where I came across it. The Doer Institute is really good about this, but if it matters, measure it. And we can talk a lot about evidence-based practice or implementation science, but until we've measured it, it's really hard to make a case that it really matters. We're just kind of talking about the clouds instead of giving people tangible, implementable change. And so as far as what we are doing, trying to not reinvent the wheel in a lot of these cases, whether there are existing instruments out there or faculty who have done some implementation science work elsewhere prior to getting here, really just trying to connect a nucleus of folks who believe in the idea and are willing to put it into practice. So a lot of what we're looking at is specific to some of the pedagogical measures, as I mentioned previously, beliefs versus practices. And so that involves a lot of qualitative. It's labor intensive to get at what someone believes about their role as an educator. What's the role of a student in the learning process? But it's just because it's labor intensive doesn't mean we shouldn't do it. And to go back to the previous question, and in my short answer, no, I find that especially in our health sciences center, the prevalence of hard scientists who want quantitative studies and the thought of doing beliefs work on a qualitative nature it's not that they're against it necessarily. They just don't fully understand that that's part of the process. So we're really trying to pour the foundation here, all that to say, before we can really get into widespread university level initiatives, it's really about organizing the resources.
Right, but it sounds like you have that foundation to build on, and that you're being intentional and you're thinking about some of these outcomes, which is very, it's a great thing for us to be doing, because perhaps in past years we weren't as intentional. And that's what IS says is be very intentional and deliberate and think about these things. We may not have the best measures, we may not have the best tools, and yes, maybe a lot of these are qualitative, and there's nothing wrong with that. Excuse me. I'm just wanting to encourage our audience to also put up your hand, your virtual hand. I'm doing my best here to scroll down the chat box, but and I cannot see all screens because we have multiple levels if you'd like to ask a question. I also know that Dr. Ewan Williams is back. Do we have you, Ewan, somewhere? Can you turn on your camera?
You briefly have me. I'm in the middle
yes.
of a brain stimulation session at the moment with a patient, so I'm kind of in and out.
I
I was going to jump
okay.
in on the questions as we go, and I'll put my camera on once I'm free from that.
Okay, would you like to, sorry, just to make sure I understand, would you like to jump in now with an answer to one of the questions?
Not with right now.
Okay,
I will jump in if
okay.
the question comes up. Sorry,
Okay.
thank you.
Perfect, great. Okay. So just continuing to scroll down here. Does anybody else, Kim or Hannah, Natalie, evaluation outcomes? I think it's such an important one. Any thoughts on how to begin? I think we've said a lot about the supports and barriers. Perhaps we can move a little bit to how do we measure? How do we evaluate all these things that we're doing? Otherwise, we're not going to be able to advocate for continuing these implementation efforts. So,
sure, I'll jump in. I think, one
Yeah.
of the things that's slightly different with implementation science too, sure, the effectiveness for what we're trying to achieve, whether it's the learner attitudes, and then getting to a later point, maybe it's even things like how many of your graduates actually do get out and work in geriatric facilities or in long-term care facilities. But choosing the outcome to match what your strategy is. So for example, if the example that I provided where we were looking to increase the reach or the coverage, just the numbers of getting the number of students that have had more exposure to service learning as the baseline, and then looking at the attitudes and how that might change over 2 years. I would also go back and look at it. We've looked at service learning outcomes. We haven't looked at it related to specifically to the ageism, but we do actually have a survey that's built into each class. And the reflections, which are part of service learning, that's automatically a component that you can actually, using the same coding system that Natalie was looking at. If you're wanting to publish it, it just means you've got to go through IRB upfront, and it does take a lot of time. So that is one of the limitations for the qualitative coding on the reflections, but it does give you a lot of very rich data. I think the only other aspect is that occasionally you will get students who will really come up and talk about the impact that it's had maybe a year later or 2 years later. And that's a really important piece that I'm not sure that we capture that as much as we could. Or if it's just one little snippet versus being the sort of dosage of it, I think that's another important question that we need to really do a bit more in our setting anyway.
Thank you, Kim. I'm just going to jump quickly to, we have a hand up, Annette. Annette, would you like to ask your question and turn your camera on as you wish? The floor is yours.
I posted my question. I'm on the road.
No. Oh, would you like me to read it? The one you have in the box?
Yes, please.
Oh, perfect. Okay, I will read the question. Increasingly functional health status in our aging population is based less on chronological age and more on the social determinants of health they began with and or attained during a lifetime, which altered their trajectory of health versus illness. Thus, we have individual populations in their 80s and 90s whose health status exceeds other populations with lower SDOH, don't you think? So if I'm understanding correctly, this seems to actually call into question what the older population really is. And maybe part of those attitudes or part of the preparation of our future learners needs to be about, what constitutes the aging population. And maybe it's not just chronological. Any thoughts, Annette? I hope I did that justice.
Yes, thank you.
Okay, you're welcome. So I'll open it up to our panelists.
I think this is one of the areas where we as educators can actually contribute to the community and the sort of social areas that we're working in, because there are always places that would absolutely love to have groups coming in and working with, whether it's an exercise class or dietetics or any type of intervention they don't get the same benefits as some of the higher economic status retirement homes, for example. So I think that's an opportunity, and I think it's something that we can certainly look for. I don't know that I've had any major issues getting contracts with the lower income housing group. In fact, they welcome it. There's potentially just limitations in terms of space, that sometimes they don't have the same space and areas to actually work in. So I don't know, Natalie, if you have any thoughts on that.
Yeah, no, I agree. Yeah, it's a really interesting perspective, and I think it also points to the magnitude of what we are working with here, because not only we have a large age range, we have a large range of functional status, and all of those different variables play a role, I think, in how we're able to tailor our education. So yeah, really interesting. I don't know that I have anything. This whole discussion is having me think a lot. I don't know that I have anything.
I think it's a great outcome, Natalie. I think that just we're getting to think, and I'm reading more and more fascinating comments in the chat box. I'd love to just read a couple here from Alan Rosen. Alan, please feel free to add here, but something that's actually very close to my heart is a relevant educational concept worth considering is professional identity formation for learners and educators, especially in promoting interdisciplinary and multidisciplinary collaborations. And I would add in working in getting our learners prepared to work as teams to then tackle or work with the aging population. I don't know, Alan, if you'd like to add anything, or that was a comment. So I'll let you take a couple of seconds if you'd like to turn on your camera. But there's another comment that is actually quite interesting here. It's about resistance to change. And so I'm wondering if our panelists have any thoughts on, can we discuss the resistance to change of professionals who've worked in healthcare environments for years or decades, and the best approaches to tackle that resistance to change, particularly as we bring our learners into the communities, into self-service learning, into fieldwork, et cetera. How do we deal with that? If especially when we need, as Kim said, our partner to collaborate, to work towards achieving these outcomes in our learners. So panelists, any thoughts? Did you encounter any resistance, or how would you deal with it?
I think that's a great point. And as I mentioned earlier, I think a lot of my work is in nursing homes, and now more than ever, I mean, if you thought there were staffing shortages and people who were burnt out and unable, before COVID, now it's even worse. There's agency staff where people, kind of fly in and they work for maybe 10 or 12 weeks and then they leave. And then so I think that one way to think through resistance to change is, depending on the setting, is to kind of validate the experiences of what people have been through, especially with COVID and the fact that everywhere is short-staffed, especially in healthcare. I really try to we try to teach our students, and we're fortunate because many of our students were nursing assistants, so they understand what it's like to have to be, cleaning up somebody's bedpan while there's like 17 call lights on, and there's all of those multiple responsibilities. And I think if we can, even at the student level, train our students to understand, if somebody snaps at you or whatever, it's not personal, right? It's like these people have been gone through, in many cases, decades of not having enough resources or training, to kind of do their jobs well. But I think when it comes to thinking about ways for people who are resistant to change, I think this reminds me a little bit of the measurement question that we talked about earlier. So when we think about implementation outcomes, what are outcomes that are meaningful to the community partners? And what are outcomes that are meaningful to the professionals that we're working with? Maybe we want to suggest something that will make their workday easier. Maybe it's something that will increase job satisfaction in some way. So thinking about many people along this continuum have such different currencies, right? The currency for a researcher is certainly not the same as the currency of a practicing clinician, right? So when we think about resistance to change, what is their currency? And sometimes I think it's actual currency or money, right? But thinking about what can we do to try to speak their language and really provide an incentive about something that they care about.
Thank you so much, Natalie. I see Alan. Alan now has your camera on. I'd like to give you the floor. I'm sorry, the multitasking was difficult. I missed you there. Please go ahead.
Alan, we can't hear you. I think your mic is disconnected.
Is this better?
Yes, thank you.
Okay, apologize. I was on a cell phone while my computer was booting up. I want to applaud everyone for being involved in all the perspectives. I think this is helpful. Some of the comments I put in the chat, we're looking at those perspectives, not just for the learners, but what our faculty members and what the teachers for the skill set. And one of the things for health education, looking at interdisciplinary integration and collaboration, the nursing students, physical therapists, respiratory therapists, and everyone else, that collaboration in those shared experiences have broader ripple effects. The other thing is then I'd just make a comment to check in during those experiences. So those of you that have led Aliki and others with the implementation and looking at the quality, I'd encourage reassessment during it. So periodically, are you structurally reassessing what are those experiences of your learners and your faculty? And what about those that are adjacent to them? And I'll leave it there. I want to give others an opportunity, but thank you all for your work.
And thank you so much, Alan. I'm glad we got to hear from you. And professional identity and working together to build that identity as a team is incredibly important. We have a PhD student who's working on that, and it's a very, very interesting and complex area. And so thank you for bringing it up. I see that we are at 3:53. So I'm wondering, there is another great point in the chat box, but I'm going to leave you with it to ponder, because I think it's $1 million question. So I'm interested in figuring out, how do we bring more learners to the field of aging studies, gerontology, aging and health professions, given all the barriers on ageism? So I know it's a really, really big question. It's really about attracting. Oh, Pamela, is that you? Would you like to say something? Your camera went on. I'll leave you. You know what? I'll give you the last word, and then I'll pass it over to Dr. Donna to close us up. Please.
Thank you so much. I'm very happy to be here with you. I'm Pam Saunders from Georgetown University. I run a master's degree in aging and health, as well as curricula for med students. And I so appreciate getting one of the last words, but one of my struggles is really bringing student learners, graduate students, even undergraduates to the field, combating those ageist stereotypes and pulling them over the hump. So once they're in, they can appreciate what a valuable person-centered experience it is. And if anyone would like to put their ideas in the chat, or maybe we can talk about it next time.
Thank you so much for bringing that up, Pamela. I was an occupational therapist back in the day with older adults, and it was a beautiful experience. And I would echo a lot of what you said. It's unfortunate we have to put so much effort, but we might get there. I'd like to pass the floor now over back to Donna. Donna, you are closing us up. I will turn off my microphone.
Wow.
Thank you, everyone.
Wow, Dr. Thomas, thank you so much for your presentation and even setting the stage for the roundtable and moderating really a phenomenal roundtable. The exchange of information was, I just think, was very powerful. It was comprehensive, and I could just see, even with some of the panelists, just the thoughts, the exchange of ideas and what was happening. I think this is so critical to the work that is set before us as we talk about our learners going forward in the future. I heard Dr. Max mentioned earlier about, hey, a decade, if we don't do something now, what might this look like in a decade? So I'm so grateful for those who have taken responsibility to be a part of this effective change that we want to make. And so I also want to thank the roundtable discussants as well for just your participation and what you've given to the health science profession, not just to this particular forum today. I believe that Dr. Maxwell as well, Dr. Benuejo also has really set a stage for today's exploration, if you will, into using implementation science and for achieving the goal of not just changing the negative attitudes, but causing us to begin to think about how to truly move forward with our learners and working with older adults. So I want to be able to close today's pre-workshop by thanking the members, of course, and the sponsors of the Global Forum on Innovation in Health, Professional Science, and Education for selecting this particular topic. I think it's very timely to talk about addressing the needs of our aging population through the health science profession education, but also the diversity of the speakers addressing the topic from various professions within the health science profession when we talk about an interdisciplinary response to this particular topic. So with that being said, I want us to continue this important conversation. You can continue it outside today, but also please join us on the 7th of December in the morning of the 8th of December, Eastern Standard Time, where we'll look at how age is defined, because that came up a couple of times today, and who makes up the health workforce caring for older adults. And as each of you are here today, consider those around you. Invite them on the 7th and the 8th to join this conversation. So please register, consider having them to register as well, because we have a responsibility to our nation. So please register if you haven't already. We just really look forward to seeing you again on the 7th. So thank you so much for joining us today.